In this video, we will be discussing about chronic encephalitis. This entity of chronic encephalitis, it uh, it encompasses three distinct clinical entities. The first is progressive multifocal leucoencephalopathy, PML. Right, it is very infamous because it is associated with HIV in most of the patients, that is 80% of the patients. What I mean to say that is all the patients who are diagnosed with PML, 80% of them will have HIV with them. Subacute sclerosing panencephalitis, SSPE. It is associated with measles virus. A hypersensitivity reaction to measles virus or autoimmunity which is triggered by measles virus. Then is the progressive rubella encephalitis seen in congenital rubella syndrome or childhood rubella or childhood rubella. Okay, we will discuss them one by one now. By chronic, what do we mean? Means that the typical features of acute encephalitis, like those of seizures, loss of consciousness, will not be there. The patient will present with fever, myalgia, fatigue, right? Uh, Decreased performance in school, dementia, etc. These will the clinical features, means kind of indolent kind of clinical picture will be there in chronic encephalitis. So starting on with progressive multifocal leucoencephalopathy. Progressive multifocal leucoencephalopathy, PML, is a disease of the white matter of the brain. It is caused by JC virus. JC virus is a polyoma virus. It targets cells that make myelin. What are the targets cells that make myelin? They are oligodendrocytes. Polyoma virus, often called JC virus, is carried by a majority of people and is harmless, except among those with the lowered immune defense. Right? It is a kind of latent infection in almost every one of us, but the situation comes when we are immunocompromised. It will cause JC virus activation and it will lead to progressive multifocal leukoencephalopathy. Right. Clinical features. It is characterized by pathological multifocal areas of demyelination of varying size distributed throughout the brain, but the spinal cord and optic nerves are spared. Sparing of spinal cord and optic nerves. Right. Multifocal areas of demyelination. For example, this is the brain. Right. There will be multifocal areas of demyelination. That is what we will see in MRI. There is characteristic pathological changes in both astrocytes and oligodendrocytes. What do you mean by this? There are bizarre nuclei in oligodendrocytes. Mitotic spindles will be seen. Right. This size will be variable. So these are the findings, I mean pathological findings, that you will see in oligodendrocytes and astrocytes in JC virus. It is induced by JC virus, right? Frequent mitotic figures, hyperchromatic deformed nuclei will also be there. Almost all patients have an underlying immunosuppressive disorder or are receiving immunotherapy, right? The patients who are on steroids, who are on natalizumab for multiple sclerosis, right? Who are on immunosuppressive drugs, checkpoint inhibitors. No, not checkpoint inhibitors, but these, right? Immunosuppressive drugs, natalizumab, etc. Almost all patients have underlying immunosuppressive disorder. Which immunosuppressive disorder? It will be HIV most of the times. What are the others are transplant recipients. They are also at risk, right? Hematological malignancies. It is given in here. 80% of patients will have AIDS, 13% will have hematologic malignancies, and 5% will be transplant recipients, and other 2% will have some other chronic inflammatory diseases. The other way around statement is that all the patients of AIDS, 5% of them will develop 5% of them will develop this, what do you call it? Hmm. This progressive multifocal leucoencephalopathy, right? 5% of patient of AIDS. Other way around, how many patients of PML will have AIDS, underlying AIDS? 80%. So these are the two statements which you need to remember by your heart. How will you diagnose PML? The diagnosis of PML is suggested by MRI. It reveals multifocal asymmetric coalescing white matter lesions located periventricularly in the centrum semiovale, parieto-occipital regions, and in the cerebellum. They are seen on T2 weighted. They can and better seen on FLAIR because the CSF signal will be expressed in FLAIR, and only the coalescing white matter lesions will be visible, right? But on T1 weighted images, the signal will be inverse. It will be decreased signal on T1 weighted. So the best image is FLAIR, I believe. HIV PML lesions are classically non-enhancing, but patients with immunomodulated drugs associated PML may have peripheral ring enhancement. It is a kind of complicated statement because you need to have an MRI. It is a comparison of different MRI images. They say कि HIV PML patients, they have non-enhancing, but those PML which are associated with drugs, they have peripheral ring enhancement, right? Peripheral ring enhancement. PML lesions are not typically associated with edema or mass effect. Okay, understood. There will be no edema, no mass effect. CSF is typically normal. Okay, but mild protein may be elevated. IgG may be found, right? Pleocytosis occurs in less than 25% patients. I mean, the CSF is not, diagnostic at all. CSF is not helpful. What is helpful? Helpful is MRI. Then another very helpful thing is this: positive CSF PCR for JC virus. Positive CSF PCR for JC virus DNA. Very important to understand. If you find JC virus DNA on PCR plus MRI lesions, it is diagnostic of PML. Now we got to understand how to diagnose PML. Positive CSF PCR findings and MRI lesions. They are diagnostic of this PML. Now here we have an T2 weighted. It is not a T2, it is a FLAIR image of flare image of this progressive multifocal leukoencephalopathy. There is this white matter enhancement. Gray matter is preserved basically. White matter is enhanced, and it is periventricular, subcortical white matter lesions. There it here it is also around the ventricle. Can you understand? Around the ventricle there is this enhancement of white matter. It is on flare. It is suggestive of PML. How do you treat this PML? See, a particular specific therapy is not available, but a few drugs, they are kind of, they have shown some benefit in PML. First is 5-HT2A receptor antagonist, which is mirtazapine. It is otherwise an antidepressant. It blocks 5-HT2A receptor. It also inhibits binding of JC virus to the oligodendrocytes. That way it will reduce the signs and symptoms, and it will decrease the progress of PML. But is it curative? It is not curative at all, because the underlying condition is something else. The pathogenesis is something else. Mirtazapine cannot reverse the changes. It cannot totally cure the disease. Mirtazapine just slows the progress of the disease. The second agent is the pembrolizumab. It is PD-1 inhibitor. It is cell signaling receptors inhibitors. This way the immunity is activated. It is very ironical here to say that, because it is seen in immunocompromised individuals. We have to stimulate the immunity of such people. To stimulate the immunity of such people, we give the drugs which stimulate the T cells. Pembrolizumab is one of them. PD-1 activation will cause suppression of T cells, but if we inhibit PD-1, it will not cause suppression of T cells, and T cells will be activated more. If they will be activated more, this clearance of the virus from the body will be more. So this way they help treat the disease. It shows some clinical benefits in some people. In a few studies it has been shown, but is it curative? It is not a very promising treatment, but this is all we have. We have mirtazapine, we have pembrolizumab to treat JC virus related progressive multifocal leukoencephalopathy. What do you do in HIV positive patient? We give heart, but still 1 year survival is only 50%. Very, very devastating condition it is. PML, the mortality rate is 50% in heart in 1 year. But among those who survive, 80% of those who survive, they have neurologic sequelae, because different areas of brain are already damaged. So this is all about the JC virus related or immunocompromisation related progressive multifocal leukoencephalopathy. It is a subacute kind of an encephalitis. So this is how you have to remember this. That is all about this PML. Now we will continue with the second chronic encephalitis, and that is subacute sclerosing panencephalitis. See, SSPE is a rare chronic progressive demyelinating disease of the CNS. It is again a demyelinating disease, right? Associated with the chronic and progressive infection of brain tissue with the measles virus. Measles virus, it will it will continue to create some underlying chronic inflammation for a very long period of time, right? The latent period is almost 20 years in some cases. Means for 20 long years the measles virus will continue to damage the CNS. Which part of CNS? The white matter. What will it cause to the white matter? It will cause demyelination. Clinical features: initial manifestations include poor school performance and mood and personality changes, right? These are the initial manifestations. Fever and headache. it will not occur, right? As the disease progresses, patient develop progressive intellectual deterioration, focal or generalized seizures. Seizures can be there, myoclonus can be there, right? Myoclonus can be there, ataxia will be there, and visual disturbances will be there. In the late stages, the patients are unresponsive, quadriparetic, hyperactive. I mean, the whole of the brain will be damaged in this case. UMN-like features will be there in UMN-like features in the late stages. How do you diagnose SSPE? We see MRI. What do you see on MRI? You will see periventricular white matter changes. These are subcortical diffuse, right? Multifocal periventricular white matter changes. This is nothing but demyelination. It is seen on T2 weighted image, but this is flare sequence because here we do not see the CSF. So it is flare. It is a flare image, FLAIR. We will see demyelination as hyperintense signal. Right. EEG will show, it is very important. It is asked in a few entrance examinations like NEET PG and NEET SS ki Radermacher complexes are seen in. It is seen in SSPE. It is non-specific slowing, but disease progression, with disease the patient develop characteristic pattern which bursts of high voltage sharp slow waves every 3 to 8 seconds followed by attenuated background. These are Radermacher complexes, also known as R waves in EEG. CSF is acellular, normal. Well, CSF is not diagnostic. We see gamma globulin level in CSF which is markedly elevated, which is more than 20% of total CSF protein. And CSF anti-measles antibody is very important because it helps in making the diagnosis. CSF anti-measles antibody levels are invariably elevated. Very important. This is very important. PCR can be done to isolate the viral genome. Okay, no problem. This is what we have discussed, the image of SSPE, periventricular white matters. Treatment of SSPE is isoprenosine 100 mg per kg per day alone or in combination with interferon alpha given intrathecally. Is reported to prolong the survival and reduce the symptoms. Is it curative? No, it is not curative, but this is all we have. Isoprenosine plus intrathecal interferon alpha, it will slow the progression of the disease and prolong the survival of the patient, right? So that is all about SSPE. Now we will continue with our third entity, that is progressive rubella panencephalitis. It is also a very rare entity and it is seen in congenital rubella syndrome patients. Means the virus is something there in the body and it is chronically active in a low amplitude, and it will cause uh, encephalitis over a long period of time. Patients develop progressive neurologic deterioration. Manifestations are similar to SSPE. CSF will show pleocytosis, slightly protein elevation. That is, I mean, viral meningitis or viral encephalitis like picture. But gamma globulin and rubella virus specific oligoclonal bands are seen. Means the antibodies against uh, measles virus in the form of IgG or oligoclonal bands, they will be seen in the CSF. No therapy is available, only vaccine can be expected to eliminate the disease. So that is all about progressive rubella encephalitis. This is a video which we have completed on chronic encephalitis. I believe you must have learned something valuable from this video. Thank you for your patient listening. Thank you very much.